It is 2 in the morning and you are standing in your own kitchen because lying down made it worse. The pain is not in your back. It is a hot wire running from your buttock, past your knee, along the outside of your calf, into your big toe. Coughing sets it off. You have discovered that sitting is the worst thing you can do, the car, the desk, the couch, and that standing up and walking a little actually takes the edge off, or it is your arm, and the only position that lets you sleep is with your hand resting on top of your head. I am Dr. Padda, and I run the Padda Institute Center for Interventional Pain Management. That posture has a name, the shoulder abduction relief sign, and it tells me more than a stack of intake forms. What you are describing is not a muscle. It is a nerve root that has become inflamed. Here's where the system fails you. You are handed a series of 3 epidural steroid injections, booked in advance, before anyone has decided which nerve root is generating your pain. The number 3 is not a biological finding. It is a scheduling convention that survived because it fills a calendar. Then it is performed without live imaging, or with imaging but no contrast, so no one can prove the medication reached the space it was aimed at. That is exactly why the FDA convened safety group, put radiographic guidance near the center of its recommendations. There is a second failure, quieter. You may be sold this procedure on numbers that were never generated in your condition. If your imaging says lumbar spinal stenosis and your legs turn heavy and dead after 2 blocks of walking and recover the moment you sit or lean on a cart, you are being quoted numbers produced in patients with disc herniation and true radicular pain. In stenosis, those same reviews found no significant short-term pain relief, possibly some improvement in disability, and that is a different promise. A clinic that will not tell you which one you have is not treating you. Understand what is happening at that root. The nucleus pulposus at the center of the disc is a vascular walled-off tissue that your immune system has very little ongoing acquaintance with, and that unfamiliarity is thought to be part of why its escape provokes such a reaction. When the annulus tears and nuclear material extrudes into the epidural space, 2 separate injuries begin. The first is mechanical. Displaced material presses on the root, and pressure tends to produce the symptoms of a conduction block. Sensory loss mapped to one dermatome, a reflex that drops out, a weak muscle. The second injury is chemical, and the evidence suggests it is the chemistry, more than the pressure, that accounts for the burning. Escape nucleus pulposus exposes the nerve root, and critically the dorsal root ganglion, to phospholipase A2, tumor necrosis factor alpha, and interleukins. That is chemical radiculitis. The ganglion is the vulnerability, less protected than the rest of the root. Inflamed, it discharges ectopically, signal with no stimulus at all. That is why your leg screams while you are lying perfectly still. Some people have dramatic herniations on film and no symptoms. The image shows geometry. It does not show chemistry. Before a needle goes near your spine, one question must be answered. Is this pain coming from a nerve root at all? In the leg, radicular pain is imitated by hip osteoarthritis, which hurts in the groin and on internal rotation, by greater trochanteric pain syndrome, which makes lying on that side impossible, by facet and sacroiliac referral, which usually stops above the knee, by diabetic lumbosacral radiculoplexus neuropathy, and by a polyneuropathy that is symmetric and stocking-shaped rather than dermatomal. In the arm, rotator cuff disease, cubital tunnel, carpal tunnel, thoracic outlet compression. Resolution requires concordance, pattern, examination, sensory and reflex findings, and imaging all pointing at one level, with electrodiagnostic testing when the picture stays muddy. When 2 adjacent levels are both plausible, a selective nerve root block becomes a test, not a treatment. Local anesthetic on one root, and your response over the next few hours is the readout. Its honest limit, anesthetic spreads, it does not respect the level I aimed at, and the evidence supporting the test is modest. I use it to break a tie, not to manufacture certainty. Now the procedure itself, a transforaminal injection, places medication in the ventral epidural space and directly onto the sleeve of the inflamed root. That is the location where the chemistry is happening. And what does the steroid do once it is there? It is thought to damp that inflammatory cascade, but that mechanism is inferred from animal work, not demonstrated in patients. We know the injection helps some people for a while. We do not fully know why. Interlaminar covers a broader posterior field. Caudal suits altered post-surgical anatomy. Every injection is performed under live fluoroscopy with contrast, and I watch it outline the route before any steroid is delivered. If contrast enters a vessel, the needle moves. That discipline is why we use digital subtraction, why particulate steroid is never used for cervical transforaminal work, and why a non-particulate steroid, dexamethasone, is what I use for a first lumbar transforaminal injection as well. Rathmel and colleagues in anesthesiology in 2015 published 17 clinical considerations for preventing neurologic complications. Because catastrophic injury, including stroke and spinal cord injury, is rare but has occurred. Rare is not zero. Less rare, and still part of what you are consenting to, the needle can breach the dura and leave you with a positional headache lasting days. And any needle that crosses skin carries a real, if small, risk of infection. I also do not deeply sedate you for a diagnostic block. I need you awake enough to tell me what you feel. Now the numbers, plainly. Arman and colleagues, writing in Neurology in 2025 for the American Academy of Neurology, reviewed 90 randomized trials. For cervical and lumbar radicular pain, epidural steroid injections probably reduce short-term pain, a success rate difference of roughly 24%, confidence interval about 13 to 35%, number needed to treat 4. The outcome measures were too heterogeneous to pool into a single effect size, and I will not claim precision the data does not contain. Chu and colleagues in Annals of Internal Medicine in 2015 found immediate improvement, averaging 7.5 points on a 100-point scale, is small and not sustained. Short-term in these reviews means 3 months or less, and repeat injections are limited by cumulative steroid exposure. In lumbar spinal stenosis, no significant short-term pain benefit at all. And in cervical stenosis, insufficient evidence to say. What it buys you is a window, the interval in which rehabilitation becomes possible. Expect a rise in blood sugar for several days, flushing, insomnia, and possibly a pain flare in the first 48 hours. And nothing on a nutrition plan will decompress a root or clear an extrusion. If you are insulin resistant, it matters here for one concrete reason. The steroid will push your glucose harder, and it will push it longer. So we manage that as part of this procedure, not as a substitute for it. Omega-3 derived resolution mediators and near-infrared photobiomodulation remain adjunctive and still emerging. Neither one is why a nerve root calms down. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. A patient presents after 11 weeks of pain running into the sole and outer edge of the foot, a diminished ankle reflex, and an MRI showing a disc extrusion at L5-S1 contacting the traversing S1 root. Everything concorded, so a transforaminal injection was performed at S1 under live fluoroscopy with contrast. The first 2 days were worse, not better, a flare expected, and still frightening at 3 in the morning. Blood sugar ran high for 4 days. By day 10, the pain had dropped enough to sleep flat, and that is when the real work started. Nerve mobilization, hip and trunk strengthening, and rebuilding the confidence to bend. Around the 3rd month, some leg pain crept back, though not to where it began, and a second injection was performed. Function held better than pain did. That pattern is common, and it is not what every patient experiences. If radiating leg or arm pain has outlasted conservative care, bring us your imaging and your story. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Ask which route, ask to see the contrast, insist on a diagnosis before a series. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.